Hi, everyone. Welcome to the Animal Heartbeat, your veterinary cardiology podcast. I'm Jose Novomatos, a veterinary cardiologist, and I'm here with Kieran and Jose, also a vet cardiologist and my podcast buddy. We have another great episode for you guys today. Right, Kieran?
It's going to be fantastic. We are honored to welcome Professor Sonya Gordon, who is the Eugene Chen Chair in Veterinary Cardiology at Texas A&M University. And Sonya is here to talk to us about dilated cardiomyopathy in dogs. Welcome, Sonya. Thank you for joining us.
I mean, thank you. It's a wonderful project you guys have undertaken to share information in a really informal and I think palatable way, especially for our younger generations who really enjoy this type of format. And I've been enjoying it as well.
Thanks. That's super kind. Sonya, your experience, your research, your expertise in DCM is huge. And there's a lot of things we can talk about. We're going to start with something just super basic. Why is DCM important? Especially why is preclinical DCM important?
Well, I feel like the game changed a little while ago. I mean, I think we always knew that it was valuable to know if your dog had disease, clearly for breeders, obviously, and then also for pet owners, maybe just to know what was expected or that there were risks. But prior to some of the data with pimobendan and vetmedin, the PROTECT and then the information on the Irish wolfhounds, right? So we had some ideas that now early treatment might matter, because as soon as you put that in the mix, now you up the game, right? Because if you tell me that I can find something, but I can't do anything about it, it doesn't matter to me as much, or it's harder to assess that value. But for a pet owner, right, to know that if you identify it earlier and intervene, you change what's going to happen, that's a game changer. So for me, it was PROTECT.
It's a big deal.
Yeah.
So preclinical dilated cardiomyopathy, you mentioned breeding and screening. Do you have different recommendations for a breeding dog versus a non-breeding dog, considering the benefit of pimobendan, as you mentioned?
Well, I think for breed screens, we usually emphasize dogs or breeds that we know have a problem. So we focus on them because the value is higher, because we have some idea of the prevalence of the disease in the breed. And so for Dobermans, it's very easy to say, yes, the recommendations are strong. I don't care if you're a breeder or not, but maybe stakes are a little higher if you're a breeder, because you're trying to better the breed and make sure it survives. And so trying to avoid pitfalls if you can is ideal. For pet owners, there's still a lot of value there. I think breed screening for other breeds where we know, my goodness, there's got to be 50, 60 breeds that have DCM identified in them, but not enough for us to know about the inheritance patterns or even the prevalence, just that it can happen across many breeds, including mixed breed dogs. So that's a harder thing, because I'm willing to screen to find something. Screening is hard when it's a very low prevalence of something you're looking for, because you're going to have probably a lot of false positives and you're going to invest a lot of effort and money. So harder when you're outside of the breeds that we know are high risk.
So thinking about different breeds, obviously a lot of the data that's out there comes from screening programs in Dobermans. That's a breed that I think most veterinary cardiologists feel they understand reasonably well. Is that the same disease in the Doberman as we see in the Irish Wolfhound or the Dog de Bordeaux, say?
I mean, is it the same disease? I mean, I think we're talking about a phenotype, a picture.
Right.
And so we're trying to bin them. Same thing happens with cats. So we're saying, if it looks like this, we will call it this. How you got there might be different, but the final circumstances are probably not so different. A heart that is dilated, a chamber, left ventricle predominantly that is weak, maybe even mitral regurgitation functional as a secondary problem, left atrial enlargement, risk of arrhythmias. So I know how to approach those things, but the how you got there part, I don't think we understand nearly as well. We just know how to identify the phenotype, and even that can be a challenge. Judging normal is harder than judging disease in some ways, right? Or the discriminating between the two in fairly well patients. And so there's the challenge. That's the challenge of preclinical DCM.
Just to get a bit an idea of how do you approach these cases? For pet owners, if we have a breed at risk, a Dobie, a Great Dane, at what age would you recommend screening for dilated cardiomyopathy? What is generally your approach?
The value always goes up. We know, especially in the Doberman, where then peak expression is probably in the 5 to 7 year range. But we've seen dogs as young as 2. So I tell people and the Doberman is definitely mature at 2, like a full body, well developed. So somewhere between 2 and 3 is nice to get that first point on the curve, because it's likely to be normal. So now you know what this dog is, and I feel like I have a good normal for them usually. Great Danes, there's a juvenile form of the disease in that breed. So I guess it would be similar. But usually they declare themselves if they develop the juvenile, they go into heart failure quite early. I would say for a Dane, I'm looking for a mature, and a giant breed dog is at least 18 months, maybe 24. So probably in the same range to get that first, point on the curve. For screening. And then the question is, can we use some surrogates for pre-screening to identify those at highest risk that would benefit from echo in a cost-effective way? But somewhere probably in that range of full-on mature body weight. And it's nice to know you're probably going to have a normal the first time. It's because now I want the comparison, because I think the deltas on these patients can be very informative as well.
I think that's really interesting, because many people think of screening as like a one-off. Now, I know the reality with acquired disease is that it shouldn't be a one-off. We should have, repeated echo over time. But what's interesting is that you're highlighting the importance of a baseline to see how the individual changes, not necessarily what the absolute values are at that time. And I think that's the first time that I've heard somebody really talk about that. It's super interesting.
I don't think we have. I think you have to understand the wiggle in the measurement, right? I mean, I'll go back. I mean, Adrian's taught me so many things. And I think about that regression to the mean with measurements, which is really a strong statement. Right. When I look at the same dog, and so a lot of times we have relationships with these breeders, and we do see the same dogs over time. Gerhard has the same sort of experience. Michael Grady did as well, and Calvert. But we see these dogs over time, and you can really, I can measure them and see the little delta, and I know what my variability is, lucky enough to have it assessed, right, in clinical studies we've actually done. So I know when I'm outside and I'm like, oh, is that a one-off? Well, we'll know on the next time, because it'll either trend, it'll keep going, or it'll wiggle back, right? And it's really quite interesting. And then if you have an unknown, I just say hold for a year if you're going to decide what to do. Because the first threshold for a breeder is, when do I want to remove them from the breeding program, versus when do I want to initiate treatment? That's a pretty clear line. I mean, I know when I'm going to start vet med, and I probably know when I'm going to start antiarrhythmics as well. But for them, they discriminating that earlier disease, it's almost like not pre, you know what I mean? B1, B2, but when do we want to remove them, or when do they truly have the disease? That's not something I try to do for pet populations as much, although, because I'm really looking to cross the threshold for treatment. And that's
the context is different, isn't it?
Slightly easier threshold, because I know when that is a little better, but the other one's harder, and the stakes are high. I've loved purebred dogs, and I want to see them do a better job, and they try, and so it's frustrating for them, but they're trying, and so you try to give them as much information as possible.
The impact of us removing a good animal from the breeding gene pool is big, isn't it? And we want to make sure we get that right.
Yeah, it's devastating. I feel really, that's the part that I feel on any of the breed screen stuff I do, where you're trying to decide, even whether you're talking, subaortic stenosis, or you're doing all these congenital clearances as well. And you're like, the stakes are high to remove a dog. And that's why the novice people, less experienced people, have less comfort navigating that normal, not normal, where do you draw the line, where it not being so strong that everything throws away. Because when you throw it all away, we are in equal trouble.
It's honestly, I think, it's one of the most difficult jobs we have. And I'm always more nervous when I do breed screening than when I'm just screening a patient, because the impact, and when you, in the first few echo images, you start seeing that's going to be a bit gray zone, is so difficult. As you were saying, the breeders are trying to do their very best, but our gold standard is not a great gold standard, and so is really a difficult job. echo is expensive, halters are expensive, seeing a cardiologist is expensive, and there are not cardiologists everywhere. So you have some very nice data recently published on risk or predictors of dilated cardiomyopathy and preclinical dilated cardiomyopathy. It would be great to talk a bit about them. So if we have a dog, if a vet sees a Dobie and the owner is not sure if they want to go ahead to echo them and so on, or cannot afford echo, which are predictors of the risk of the disease? Which variables can vets identify on, for example, on physical examination to start with, that would mean that that dog might be at an increased risk of having preclinical DCM and should really have an echo?
So I think there are cost-effective ways to, especially when it's the pet owner, although the breeders are often interested in what their pet population is doing, the smart ones. But what we did is we looked at biomarkers, so NT-proBNP. I mean, we also think about troponin, but it's more of an injury marker versus a stress marker, but it potentially has a role to play. And then sort of the short ECG, the 3-minute or the 5-minute or some recording mechanism. I mean, the way I think about DCM and Doberman is that most dogs that have important treatable disease have structural changes on echo. There are some that only have arrhythmias, right? I mean, we find them, their echo looks pretty good and they still have arrhythmias. And we know that 30% of dogs, first thing they'll do is sudden death. Although I don't feel we have proof that we impact that aspect of the disease as much as progression to heart failure. So I might focus more on who are the dogs that would have the echo phenotype, because I really feel like those dogs benefit from a treatment that I know works. The gold standard, of course, is to include arrhythmia assessment separate from that. But I think catching the ones that have structural disease, and I know Gerhard feels the same way, that when you have the underlying phenotype structurally, the arrhythmia part is worse anyway, or riskier, if you will. So if we focus on that and we say that is highest priority, then biomarker wins, right? So I'd say NT-proBNP, although it has lots of wiggle, and there's some breed stuff that we need to be concerned about and things like that, it has been evaluated specifically for this question in Dobermans. And so I think if you're looking for a pre-screen that beyond being a Doberman of a certain age, and that assumes you didn't find a physical exam clue, because those are also, very informative, pulse deficits or an arrhythmia that you don't think is sinus, or frankly, a murmur, right? A soft murmur. In these guys, there's probably much more, and gallops, which we know most people don't pick up. Assuming you find nothing on physical exam, a biomarker like NT-proBNP has high value. We know the cutoff that if you want high sensitivity, and that's, again, screening test, right? You would like to not miss anybody, but still have some specificity so that you're actually weeding down the population that undergoes the more expensive testing. So 450 is probably the cutoff if you want high sensitivity. Probably more like 750 starts to, maybe your specificity gets a little higher there. Certainly, biomarker doesn't confirm a diagnosis at all. It just pretty much escalates your risk such that your value in echo at that point is probably higher. I always tell people, if you're going to echo your Doberman once, do it when the biomarker is high, right? Because you're much more likely to get a hit. I know that if I echo a bunch of Dobermans, even though lifetime risk is high, people, 50, 60%, but that's not the same as the hit rate on an individual day. If I echo 100 dogs, I'm going to find probably 10 to 12% on a given day. That assumes they're not bringing me all 2-year-olds. So give me a population that is representative, and it's probably not going to be more than that. So they don't have a 60% risk every time you see them, right? So I think biomarkers make good sense as a pre-screening tool to identify risk escalation and enhance the value of a scanning study at that point.
And do you think the change in the biomarker is as useful as an absolute value? Do you think it's worth getting a baseline biomarker early on?
Well, that's, again, the wiggle in that test, right? I mean, I think the delta is what we're interested in, and we're actually actively looking at some of those questions, but there's certainly nothing in Dobermans for me to be able to reflect on. I think if you wanted added value and you were looking for blood tests, the problem a little bit is how people price that test, because some places charge a fair amount for it. And if they charge $200 for it, it's not valuable anymore, frankly, or the value goes down, right? So if it's done in a way that, that it's not, I mean, to me, it should have been a below $100 test, right? Something that's easy accessible by primary care veterinarian, but we don't get a chance to price it. And IDEXX doesn't price it at $200, but veterinarians decide how they want to price these things, and that makes an impact, I guess. There's another point of care quantitative test out there now. BioNote has one that'll put both NT-proBNP and troponin in your practice. We've validated dogs, normals, and now some geriatrics, and my colleague Ryan, I think we did cats together. So what we don't have is the threshold cutoffs, but in hospital testing always tends to be more cost effective. It is the V-check. That is the
V-check machine.
Is the NT-proBNP BioNote. Yes.
Right.
Yeah. So it is. I think it's nice to have that available, but and I think that if you're okay, so we did variability work on NT-proBNP, right? We did mostly mitral valve disease dogs and normal, and it's almost a 50% change. So you would have to pretty much double your value for me to believe that it was a real change and not a day-to-day variability. So if you were looking at Dobermans and your Doberman was 400, 300, 200, go along, and then all of a sudden it's 900, I agree, that would be. But he's also crossed my species threshold, or my breed threshold for that at that number as well. So I think we're looking at trending deltas in valve disease dogs as well at later stages to try to predict adverse events. In people, they treat the number, right?
Right. Yeah, it's interesting that the idea of treating to obtain a particular NT-proBNP value. I mean, that's fascinating area, isn't it? We're going off topic a little bit here, but I think that's a really interesting idea. And I wonder if that's something that could help us optimize pimobendan dose or something like that.
Yeah. Well, avoiding catastrophes, right? I mean, it's that if something's pending, it's kind of what we do when we're trying to navigate our flight paths these days.
It's true. It's true.
Yeah. So NT-proBNP, you show that outperforms troponin I. So if one needs to pick one biomarker, it would be NT-proBNP. Is there any value to run both biomarkers? Would you get more information if you run both versus just NT-proBNP?
I think the answer is yes. That together they might give you a better signal of higher risk. I have much respect for troponin I being up. That's a different kind of story. And you give me a biomarker that's elevated as well as troponin I that's elevated, and I'll give you a dog that's under high risk. But now they charge again another. So you have to look at the cost effectiveness, and if you could batch that as this is your Doberman annual pre-screen. It's a NT-proBNP, troponin I, and a 2-minute ECG, and that was cost effective, and then that channeled them into more advanced testing, Holters and echoes by people. Because again, we're talking about probably not what I would call a basic scan at that point. This is the scan that needs to be done by someone with skill. It doesn't have to be a cardiologist, but it needs to be. I mean, it's dead on easy to diagnose overt DCM and valve disease and stage mitral valve disease and measure the left atrium. It is not a dead on easy task to discriminate preclinical DCM from normal. I wish I was able to help think about how do you price these, because I think it's how they're priced that really impacts how they're used.
It's definitely a challenge, isn't it? Just sticking with the idea of these non-echo, non-Holter based screening tools. Obviously, we've got genetic mutations in Dobies. How useful are those, do you think, in your hands? What's your approach to using those genetic testing, and what are the limitations out there for vets?
So, it's kind of like I call it the cardiology toolbox talk for my students. And
I love that talk.
Genetic tests.
When you visited, you gave it to my students, and it's a great format in which to teach. I love that. It's great.
So and genetic tests are this, whatever 3 minutes at the end, and it's like so that they know that they exist and that it's probably going to be more of them over time. These mutations identify patients that have risk, but we don't always understand whether that risk will express itself in a phenotype that's of importance. So for breeders, I say this is a tool breeders should use. They should breed away from things that they know have a risk. And even if we don't know that every dog with a genetic mutation will express the disease, they can take that into consideration as they choose their pedigrees, and that makes sense, right? So we have two genes that they look for here, PDK4, and then they call it DCM2, that, the Kate Mears panel at North Carolina. And the thing is, to me, whether you talk cats or dogs, the genotype testing does not replace phenotypic evaluation because there's no guarantees. We see dogs that have normal for both of the mutations that have DCM and vice versa. I've screened dogs for years that have mutations that do not go on to express the phenotype. So I think it's useful, less useful to a pet owner, and maybe even discouraging for a pet owner because they're sold a dog and they're told they don't have the mutation. And they don't understand that that's not a free pass on phenotypic testing.
Right.
It's good. Yeah. I mean, it's better to have a Doberman without those genes, I'll be honest, right? But it certainly doesn't, maybe there's a false sense of safety that is conveyed maybe inappropriately sometimes by some breeders. Like I said, I love breeders. I assume they're all great, but we all know they're not all great. So that's how I use it. I use it with knowledge or put it in context, but it doesn't replace phenotypic testing. And I'm excited to have mutations to try to, streamline the process. Again, risk assessment. When we built it into the modeling, it for Dobermans, it stayed in, but it's not as again by itself. It's not predictive, right? It's not. You can't guarantee phenotypic changes based on it.
And do you, forgive my ignorance on this topic, but do you understand the difference between the homozygous versus the heterozygous results there? Like we see the partial dominant effect or rather incomplete dominance, in HCM in cats with the myosin binding protein C3 mutations, where the heterozygous, they really just live a normal life, and the homozygous are much more likely to be affected in young adulthood. Is that something that's mirrored here with the DCM mutations or not?
So it's interesting. I almost, because on the OFA screening forms, there's a place to write down. So we always ask about the genetics for the patients. And I've worked with like a lot of Dobermans, and I would tell you, I can't recall the last time somebody told me they were homozygote for one of those. So does that mean I'm never seeing them because they don't exist and we don't get those dogs very often? I don't know, but I think it's very unusual for me to have a homozygote. And I don't remember ever testing one myself that was a homozygote. So again, makes you wonder if that's a more lethal variant, but I'm not sure of that either. I guess it'd be nice to ask Kate.
In human HCM, especially when you have double hits and two mutations affecting the sarcomere, in this case, of course, the phenotype will be more severe and then develop earlier. Have you seen cases with TITIN mutation, positive to TITIN and positive to PDK4? Have you seen those cases, and do you have any feeling if those double hits would have a worse phenotype than the ones that only have one mutation?
I've got Dobermans that have been coming up with both, like that they'll say they're heterozygote for both, but I have not. I don't know that we've had them that test out long enough to really get the 5-year effect where we sort of had the other one for quite some time, enough to become a little, not blasé, but enough to challenge it as an end all and be all for diagnosing the disease, because you watch these dogs and nothing happens. And there's a difference between cause and effect or along for the ride. And I think we all have these questions about these mutations, and are they for sure driving the process alone or not? It's not simple. I think we all hope genetics would be simple, and it turns out it's more complex than anything, especially given individual mutations occur anyway. Or it's like, I don't know, needle in haystack.
Right. The more we know, the less we understand, I think, with the genetic markers.
Clinicians, we just need to be aware of what's there and recognize that they would need to go a long way further to get us to think that phenotypic testing was not valuable. And even the genetics people know that, right? So I just think we have to follow it and keep it in context, but be cautious.
Yeah. And client communication, as you were saying, is really important to explain the breeders and the pet owners that a positive gene test or heterozygous for a certain mutation doesn't mean they will develop the phenotype. Because indeed, cardiomyopathy is so complex. The incomplete penetrance and the expression of the diseases, the age-related penetrance, there are so many factors that may affect the phenotype of the patient. very interesting, but indeed, in one hand, a bit frustrating because it would be so nice to have like this beautiful monogenic disease where you do the gene test, that's it. You go, you are not good, you are good. And yeah, we would carry on.
Reality is not like that, is it? Normally in
Exactly.
biology is full of
Yeah.
gray areas, you know.
Yeah.
So moving away from Doberman specifically, I think if most of us saw a 6-year-old Doberman who presented with an arrhythmia and we evaluate them on echo and we see increased dimensions, poor systolic function, we're pretty much going to call them DCM. If it's a different breed, if it's not a Doberman, it's not an Irish Wolfhound, it's something a little bit more atypical, we maybe begin to think of other disorders. What are your top phenocopies for the DCM phenotype? So what are your top differentials that could be causing a DCM phenotype that's not a primary myocardial disease?
Myocarditis for us, in particular, Chagas disease.
Yeah,
but
that's really
myocarditis
interesting, isn't it? It's very different geographically.
But myocarditis in general, I don't think we understand how, prevalent or the potential etiologies and how some of those might even be transient events that occur. But myocarditis, and then probably, especially if they have arrhythmias, is it egg or chicken? So arrhythmia induced, and not even tachyarrhythmia, right? I mean, if you believe some of the work, it's just arrhythmia induced, and non-sinus rhythms are naughty. And so those would be the first two things. And then, you'd also put that on context of, is there a systemic? I mean, if they're, I hate, the dogs they drag down from ICU that are dying of a million things, their hearts aren't happy. And they're along for the ride. So, is there a sick thyroid part to it, or a true hypothyroid? History of drug, chemotherapy drugs would be nice to know. And then I start to think about nutritional. I mean, it's on my list, right? It's not number one, but even before we had these last, few years of issues, we knew for a long time there were potential problems with some dogs, and maybe it wasn't what they were eating, but maybe how they absorb it or how they process particular nutrients. I mean, taurine being one of those. So diet. I mean, so it's, I always say DCM is messier. I mean, I think if you identified the phenotype, I know how to treat it. But if you ask me how they got there, and I've even stopped saying, oh, you're a Doberman, you just have Doberman disease, because frankly, some of them don't have Doberman disease.
I think we've all been caught out by that, haven't we?
Yeah. So it's expensive. So we would do, the workup for preclinical DCM beyond the echo is even expensive. By the time you start screening for myocarditis and screening for arrhythmias and screening for, diseases like thyroid, I can rack up a lot of, and good nutrition history, of course. But if you want to start measuring whole blood taurine and plasma taurine, I can really start spending your money, right? I mean, it's easy.
Sure, they're not cheap tests, are they?
No. Talking about phenocopies, there was this recent case series on Addisonian dogs with hypoadrenocorticism and DCM phenotype. We have had, last week or 2 weeks ago, we had a dog that came through medicine with Addison and then ended up developing pulmonary edema. Have you seen these cases? Have you seen these Addisonians developing a DCM phenotype? And when do you generally diagnose them?
So sadly, one of my experiences with that is my own dog, who's no longer with me, standard poodle. And so it depends, I guess, where they're at in their treatment plan. So when they use the repositol mineralocorticoid injections, those things change plasma volume pretty dramatically. And so for my dog, he went into heart failure after receiving that injection. And I think he had a little bit underlying because he'd had a PDA as a puppy. So maybe some residual systolic, chambers, but not terrible. But his blood pressure went to 180, 200 on that drug. And you've seen what acute afterload changes do. I mean, a lot of hearts really can't respond to that. I mean, think about teaching in echo labs when somebody's used dextomator. They develop MR, a lot of them AI, and their function looks like crap. So I wonder in the Addisonian dogs, because the other flip side is when they're undiagnosed, they're hypotensive, so again, is that to me a chronic adrenergic stimulus? So I could see how you could tie in that kind of endocrine related effects. And then I think there's no way they're not interdigitated with thyroid, because, the thyroid is part, so whether it's sick thyroid, maybe they're just down regulating their thyroid, but I find it intriguing to look at our patients with volume statuses that are not normal, whether they're hypovolemic or hypervolemic, because we get those, they bring them down after they've given a bunch of fluids.
Exactly.
And throw in
They're very
steroids.
difficult to interpret, aren't they, those cases?
Yes, really. And then add in they're ill, like they're systemically ill.
Right.
Not just because they're not there to get fluids, they're there because they're sick, and then steroids. And then the repositol type steroids, especially when you start messing with mineralocorticoids. I would say the heart's a bystander in that scenario. But I have great respect for if you're going to start giving those types of medications, it might be worth knowing what you're starting with. So, because if they have any underlying structural disease, I think they'll be much more likely to have problems associated with those types. We see this I'm looking at a big group of cats from IDEXX, like 2,000 cats, so they're telemedicine cats, but it is amazing how many cats have a steroid injection prior to presenting for heart failure. And I've seen 4 of those lately, and it's like they're given these repositol injections, and you get them in and they're in heart failure. and you're like, well, is it because, or is it, I think it's just unmasked sometimes what was there, or maybe they had a phenotype and now you unmask it. But sheesh.
Exactly.
Wow.
Yeah, that's very interesting. As you're exactly, because the changes, the volume status, the sudden change in volume status are very interesting, but huge and dramatic. And you see, Kieran, Sonya just started talking about cats, wasn't me? Because Kieran always blames me, like, I always talk about cats, it's mitral valve disease, and talk about cats. But yeah, steroids. It's but now that you talked about it, because very commonly people ask vets, cardiologists about the risk of giving steroids to dogs with underlying heart disease, mitral valve disease, DCM, considering the apparent relationship or association between steroids and heart failure in cats. Have you ever seen dogs with preclinical DCM, preclinical mitral valve disease going into congestive heart failure after they receive steroids?
I cannot recall. In fact, I often, as part of a talk, I give people permission to use but the low doses, right? Like the anti-inflammatory, the respiratory type stuff, and short courses, and trying to use inhaled when we can, because I say that if you give a little bit of pred to a dog and they go into heart, they were there. That's like them probably going
You've
down.
Not pushed them very hard, have you?
No, you have not pushed them very hard. But I think it's like a sodium load. It's like if you gave them a bag of potato chips, they might also unmask themselves. Because I've seen dogs go down to the Gulf of Mexico for the weekend with their parents that are, and drink the water, which is full of salt, probably other things too. But they drink and then they decompensate. And so, I mean, we know sodium loading and steroids are really that kind of thing. So I think you have to use them with caution, but I think there are still drugs that need to be part of the toolbox for the old small dog who coughs, right? If you don't manage inflammation, you don't manage airway disease.
I have some questions about myocarditis. This is a conversation I often have with my colleagues, and I've gone on a real journey over the last decade in terms of beginning really as someone who said myocarditis happens in Texas. It doesn't really happen anywhere else. I don't think I ever saw a case that I believed had myocarditis before that. And if you look at the literature, aside from Chagas disease, which obviously you're very familiar with, there's not a deal of great diagnostics to confirm myocarditis of any origin, infectious or otherwise, in dogs. Since then, I've seen a ton of myocarditis, which, I'm very conservative about my diagnosis. And I would say that for me, the criteria in the UK for a diagnosis of myocarditis is a dog who appears systemically unwell. They may or may not have heart failure. They've got arrhythmias, supraventricular or ventricular or blocks. They've got a high troponin, and they've also got systolic dysfunction minus pericardial effusion. So I'm quite tight on evidence for myocarditis. Some people will say a high troponin equals myocarditis, and I don't buy that. What are your thoughts, and what do you see aside from the Chagas disease, which I'm very, very happy for you to talk about, because it's a really interesting area that a lot of our listeners may see and that we know nothing about because we just don't see it as clinicians?
I think it's like anything. If you don't look for it, you never find it, right? But it makes sense that there's more than just these cardiomyopathy type problems out there that are destined to happen by a mutation or something. So and I think part of it is that we know it's common. We know people get myocarditis, and we know a lot of it's viral. So I think we don't even know what we're looking for it. And I did toxicology as an undergrad, and I'm always reminded that you can't find the toxin that you don't know what you're looking for. It's like, again, hit needle in the haystack. And so, given we don't know what agent, we know parvo. I mean, we know some of the viruses that had tropisms for the heart. So there's some knowledge there. What I do know is that if you look at dogs with spontaneous heart diseases like valve disease and DCM, even when they're the sickest of the sick, their troponins are only mildly elevated relative to normal. They got to have something bad happening to start having injury markers like troponin be an order of magnitude higher, which is what we're talking about here, right? Like, we're not talking mild elevations, we're talking pretty obvious. And especially you couple that to, I don't have another reason for this arrhythmia, in a dog that lives in an area where infectious disease, which is pretty much everywhere, let's be honest, even if it's not Chagas. So, and it's one of those, I see a mild systolic dysfunction and you're like, well, is that normal for this dog, or is that something cooking, right? It's like, if you couple mild echo changes to me with a biomarker that's elevated, troponin or BMP or an arrhythmia, it's like when you stack the evidence, you become more suspicious. And that's what you said, you have a hard line, and that's because you want multiple pieces of evidence to support the conclusion, which again is funny because I don't have a specific treatment for myocarditis.
No,
right?
no, it's true. What do we do?
So you're going to monitor. And I think some of it can be transient, right? Like, I think I put pacemakers in dogs with third-degree heart block that then didn't need their pacemaker 6 or 8 months later. And I assume that was a myocarditis. I mean, the reality is the dog would have died without the pacemaker, so it's still the right thing. But I think you don't know whether they're going to be progressive or not. We don't even know that with Chagas, and we don't even have a confirmed way to diagnose that disease easily. So I think it's got to be on your mind, because it probably at least warrants for investigation over time, right? Because you want to make sure if they do progress to a certain point, you're probably going to treat them. If you suspect it, you're probably going to look at them for arrhythmias that maybe you could do something about. But as for a patient, for a client, it's hard, because the diagnosis is it's a little nebulous, because it just means, I believe your dog has something that may or may not be progressive. I'm looking for thresholds for intervention that I think will change the outcome, but there's no treatment specifically. You'd have to biopsy, right? You'd have to know whether you need interferon. Do you need steroids or interferon? Right. I mean, so is it now becoming an immune mediated progressive thing related to your own body, or are you an active infection? And even biopsying for people is hard, because they'll biopsy the right side and you may not get the right spot. So PCR becomes, if you know what you're looking for, maybe it's a PCR. Even with cats, right? It's like, right? There's more going on there than meets the eye. These transient myocardial thickening cats. I mean, maybe there's more going on with myocarditis. I've always said that. I know you and I talked about this a number of years ago, Kieran, and that maybe was in your gray zone years for myocarditis.
I'm converted now. It happens. But I think I went full in. I've biopsied a number of cases when they've been stable enough to anesthetize them for biopsy. I've always been really disappointed in the results, because I think we don't know what we're looking for. So what do you PCR for? Do you PCR for everything? And in fact, when you get a PCR, what does it mean? Because the work out of, I think it was Iowa State or Jess Ward and her team, looking at formalin fixed samples, they looked at a control group of dogs who didn't have heart disease and a group of dogs who fitted criteria for myocarditis. And there was as high a proportion of dogs who tested positive for various infectious diseases from the normal group as there were from the abnormal group. So what the heck does it mean? Even if we do go down the road of biopsy, I'm not sure we know.
I think Santilli did some of the same work with some of the heart block dogs, and agreed, it becomes more confusing than helpful. Certainly not warranting an invasive test like a biopsy, but not that they don't tolerate them. It's just that it's expensive and it is an anesthesia event.
I think it's limited utility. So when you combine that, it doesn't make us desperate to do it, does it?
No. Now I'm going to be the doctor who's treating the patient who's in front of you. I mean, we look for tick titers or tick-borne diseases, because but if I just played the game, which is the treatable things that I'm thinking about, they're not viruses, probably mostly viruses. If they're going to get better, they're going to go away. And there's probably not a lot I can do about a virus. But a lot of the infectious diseases that I'm worried about, Chagas aside, would be maybe responsive to doxycycline or minocycline. So around a good round of a decent, and it's also got immune modulatory property. So if it were my dog, it would probably minimally, I'd be doing like tick hunts, like tick-borne disease. I mean, we do a panel probably at North Carolina. And we've come up, I mean, of course, we have all that here as well, but anaplasmosis, nobody's done links specifically. We always say tick-borne diseases can cause myocarditis. I do believe I've seen cases where that's true. And so at least a round of doxycycline makes sense. And it'd be interesting to look at that even as if you meet your criteria for myocarditis, if everybody agreed this is a myocarditis case, and then they either do or don't get 30 days of doxy, and then you just reassess. I mean, I do like to see troponin coming down. I do think that probably means, unless you burned out your entire heart, which I think is almost it, because even the dogs with really not much left still have high troponins when they're dying. But a trend down makes me really happy when I'm managing what I think is a myocarditis. But they do drop, like they go back to normal in some of these cases, right? And sometimes they don't. Yeah, we need more, maybe like almost like a registry type situation or something where you could start to have, a group that's across globally more. I mean, I think we need more of that type of stuff because there's lots to be learned from observational studies, and just comparing across the continents in particular, because we have different challenges.
We talked with Adrian a bit about that. It would be so nice to have large disease registries, as Michael Borgarelli has with mitral valve disease and so on. And as you were saying, to have that across the world would be so nice to get very large numbers on observational data. Because I also do love myocarditis, and it's so frustrating at times, even when you get a positive titer on serology for whatever infectious cause. Is that just a bystander? Because looking at the TMT cats, for example, we had guys that were positive for Bertonello with IIGGs or IIGMs that then went to IIGGs. Some we treated, others we did not treat, and they still reverse remodeled and normalized. And so difficult to know how, even with the positive serology, if that bug is really the responsible for the inflammation. So very, very cool stuff indeed.
People, they want you to have a confirmation test, right? So even for a disease like Chagas, you have to have a second test to confirm. We don't even have a first test that we believe, and so it's not surprising. The second test could be a biopsy in a human, but they want a second test, a confirmation test. I mean, Chagas is really problematic for us. It's sad right now here, because there are a variety of tests, and none of them are probably perfect. But there's one that's probably really, really, really overcalling. And what's happening is people are using a combination of itraconazole and amiodarone in dogs that just have a blood test they're normal otherwise. And they're maybe not even getting phenotypic screening to see if they have anything else to point them in the direction. And then they take a combination of medications that you and I know has important potential or probable adverse events, right?
Right.
And so expensive. And so right now I feel like there's so much cloudiness around the diagnosis. We're working actively on trying to demystify that a little bit. But in terms of having a baseline test, because some of the serology, the IFAs are not confirmatory, they're suspicious. And if you gave me a dog with a phenotype that also fit, like at least arrhythmias or something that made you do the test, right? I always think about it when you have no index of suspicion for the thing and you go looking for the thing, right? It doesn't matter how good the test is. Heartworm testing in Canada makes a lot of false positives. It's just, even though it's a very, very good test. And so when we start doing testing on dogs that have no reason for testing, we have to anticipate false positives. And when that action step is invasive, chronic drug treatment, those are big steps. And the lay
especially
people,
with those drugs,
and they're scared. And the people, the pet owners are reading, and they're not able to digest the information, and so then they get scared and they want to do treatments and they're preyed upon.
Going back to DCM and arrhythmias.
Let's get out of that one rabbit hole.
Maybe we should remind our listeners that DCM, preclinical DCM, may have two slightly different phenotypes. We may have structural changes with or without arrhythmias, or may only have arrhythmias without structural changes. So it seems easier to predict the case with structural changes. The case with arrhythmias are more difficult. The arrhythmogenic, electrical, the arrangement case are more difficult to predict. And so Holter is mandatory, is the way to assess the burden of arrhythmias and the malignancy and so on. We would love to have your opinion and on maybe two different questions here. One is, do you have any idea, any feeling, any data on the daily variability of ventricular arrhythmias in dogies? Is it as high as we know or has been described in dogies and humans? And with that, how long are your Holters? Does it matter? Is it important? Should we try to do longer Holters than just 24 hours? Is it reasonable to say, let's do it 48 hours, let's do it 7 days, as there is a recent work about it? What are your thoughts and your approach for screening dogies with arrhythmias?
Boy, I've listened to Gerhard. I even listened to your podcast with Gerhard. I know there's a lot of questions about duration. I mean, for years we were happy to get 24 hours, right? And maybe get 20 out of the 24 hours that are analyzable. And I know that when they go home, yeah, they're more stimulated. They just had the thing put on. But the truth is, it's kind of like if you have a dog, how many dogs do you have on your echo table that have benign ventricular arrhythmias? They're stressed, right? The dogs are in the hospital. And it's just not a common thing for dogs to have ventricular arrhythmias without a reason. It might be extracardiac, but they usually have a reason. And if you can stimulate arrhythmias with high adrenergic tone, probably you have some predilection for arrhythmias, because most dogs under high adrenergic tone don't do that. So I'm not necessarily concerned that it's a one-day Holter. I think certainly much better to have a one-day Holter than to have just a 3-minute strip in the hospital. Our place charges us maybe slightly different if we give them 2 days. I'm sure if we gave them 3 days, I think you guys said, well, what if you run it for 3 days and you don't even look at the first day? But if you're not looking at the first day, I would ask you if he had sustained VTAC, it would still matter to me that it was in the first day. I don't really
change how we thought about the case, wouldn't it?
Oh, it would absolutely. So it's kind of like, or do you put loop recorders in them and just, so where do we stop or end with all that stuff? But some sort of larger piece is obviously valuable. I think finding evidence of complex arrhythmias and whether you want to use like a modifying Lange score. Gerhard's commented on instantaneous coupling rates greater than 260 is important. We've known that for a while, at least in Dobermans. We've always known RNT made us more nervous, which is kind of saying a little bit of the same thing. Yeah. We always look at singles, occasional singles, a lot different than, pairs. If you got your friends with you, probably it's a little more dangerous, right? Pairs and couplets and bigeminy and trigeminy, where you get into a pattern, probably more important. Normal dogs have a few sometimes, right? Like especially older dogs. I don't know if we're doing the dog aging study and the RAPA portion of the rapamycin arm of that triad. And we've had to, throw out dogs with arrhythmias and Holter dogs if we have an index of suspicion. And some older dogs have an occasional, where do you stop? Look at the spleen, look at you have to go wandering down the pathway, check the troponin, check the Chagas. It leads to an entire pathway of events. And some of those dogs we've ended up tossing, and I think some we've kept as long as it was less than 25 on the Holter. It's 25 singles or something like that on a 24 hours coming out of the hospital, which I think is what was reported early days. I think we all have some acceptance of a few. Anything that makes things more expensive is hard right now without a high value item. So going to 3 days as a routine recommendation, I might struggle with but I do think there's tons of variability. The Doberman, so I just made a decision on a dog I saw. It's one of my chronic cases, and she's also a Doberman owner from a long time. So she's lived through this a lot. So I think he was enough for me to be suspicious, and I kind of do the Gerhard thing because he had borderline, and I think it was like, I don't know, 100 or something, and they were singles, and I was like, okay. And she's not going to breed this dog. She's a breeder, but this is a obedience dog for her. So we're not thinking about that. She's more about the dog right now. and not the breeding potential. So I said, well, I wouldn't treat that. I bet you the echo's normal right now, but this is coming, right? So we set it up for 6 months, and sure enough, after 6 months, it was obvious. It was orders of magnitude. We went to hundreds, like not 100. It was like 600, 700. And then I was still like, do I want to treat her? Because she didn't have runs or pairs. And I just said, I turned around and I said, I don't care when, a month, 2 weeks, give me a second one. See, I think it would be more important to me to have two that are separate from each other than 3 days in a row.
Yeah, that's a good point.
Yeah. So she did it again for me, and now it's, 10,000. So my point is, I was right. This dog is, and I've started treatment. So it was enough, and she was willing to repeat it, I guess. I mean, they own their own halters, a lot of these people, right? So they're
a lot of our Adobe breeders have their own halter, and so the halters happen. I never see them. I see the dogs when the halter comes back with a lot of VPCs. Then they come for their echo.
Yeah, but there is a ton of variability. Like at least even when you're managing diseases, right? That's why I say when they treat, I said you can re-echo them to see if the treatment is working. But if you're already on sotalol and mixotil, I got nothing much left, and I'm probably not going to shift you to amio very easily unless you have clinical decompensation. So rechecking, but it's 50 to 100% variability, right? I mean, it's a lot.
It's huge. It's huge. Yeah.
I mean, obviously, if they're syncopal, it's easy because you're like, okay, they're critical for their disease. But I always tell people, the way I approach it is, I have no freaking idea if treating arrhythmias makes a difference beyond treating the structural disease if it's present underneath, because I think that helps, right? Protect showed us that make the heart happier, you'll impact both the sudden death aspect and the heart failure aspect.
Right.
But beyond that, I don't know. And so I'm like, okay, I'm selling you an insurance policy. I think it's the right thing to do. And I always tell the residents that once you recheck it, unless they want to go, if you're on sotalol already, and they're not going to put the dog on mixotil 3 times a day, and by that adverse event profile, I probably would say rechecking the halter has mixed benefits, because if you're not going to change anything, and I know the variability is high, and here's the other thing. I don't know that what we don't do is just change the fibrillation threshold. Maybe you still keep having as many arrhythmias, but you're less likely to hit the magic one, right? The one that goes into the sustained VTAC. I mean, I've seen dogs in VTAC in the hospital with arrhythmias like you cannot even believe. And I'm like, and you're messing around with them for an hour or two trying to convert them, and they're not dead yet. And you're like, I'm going, clearly not the day, right? I mean, this dog has every reason to have gone into fibrillate, and he hasn't actually fibrillated. He's still in a rhythm. Whereas, one magic beat and you're off and running. So we don't understand. I think even our drugs we have limited drugs, right? Limited. We interviewed somebody just for one of our biomedical science positions they are all cardiovascular researchers, and they're looking at new targets for antiarrhythmic agents that are they're all sarcoplasmic reticulum related. They study the SR and the ryanodine receptor, and they're looking at some of the, I mean, it goes way beyond my depth of stuff, but identifying regions on the ryanodine receptor that not only open channels, but closed channels. And if you could close the channels with a very directed agent against the specific part, you could potentially change the amount of calcium. And remember, a lot of arrhythmiogenesis is related to abnormal calcium handling, and most of the diseases affect the ryanodine receptor in multiple aspects, or that TMP, whatever the bridging set of molecules that have to allow it to talk to the T tubules. So there's but it was interesting to hear her talking about aspects of potential new molecules that might be, because a safe antiarrhythmic drug, right, would be very valuable.
Really specific.
Yeah, and in humans, it's been very it seems like that's a pathway that's almost dead, because it's all gone to device-based management,
right,
and fixing or ablation type approaches, right? Like find them and get rid of them, versus a drug, because the drugs bring lots of other things to the table.
Yeah.
And you guys don't even have mexilotine, right? Do you only have sotalol and amio?
No, we have mexilotine. We can import it. We also there is a compounding pharmacy company in the UK who produce mexilotine, which is what I tend to go for.
Do you have procainamide? Do you have procainamide still?
We have to import procainamide.
We don't have it.
No, I think from somewhere in Europe, I think, but it's very expensive. I actually don't keep it on the shelf anymore. because it's so expensive and it's so rarely that I would reach for it. We do use the preservative-free amiodarone, the Nexterone from the US. Again, very expensive, but that is something that we have access to through the import. But otherwise, for us, injectable, it's lidocaine. We can import diltiazem, so we have diltiazem too.
Yeah, Sotalol. We have Sotalol IV. That's really interesting what you're saying, Sonya. That's very valuable. That we started Sotalol, we had Mexiletine, and we have so many times this discussion. Are we just treating an ECG then? How aggressive should we be? Do we drop the numbers to how low? And of course, all the pro-arrhythmic effects that the drugs might have and so on. Very challenging. But now that do you have any experience with class 1C drugs like flecainide and so on? Because there was a discussion in the forum the other day, and we use flecainide now in 2 dogs because they did not tolerate Mexiletine. They become very anorexic, a lot of GI signs and so on. And we end up using flecainide, and well, N of 2 seemed to respond okay. Have you used 1C classes? And
We've used that again a couple times because again, Mexiletine was hard to get. I feel like it's like whatever is in your closet, you have to try to use. And we do. And again, most of us don't want to reach for amiodarone very quickly. Although in terminal, if I always say if the dog is destined to live less than 6 months or so, I'm quite happy to use amio. It tends to work quite well, and most of the adverse effects at milder doses are manageable. But flecainide is another one we get. For us, it's intermittently available. And so that's limited. So I've only used it a couple times. John Bonagura said that early days they used it a lot more. I mean, we used procainamide a lot more back in those days when it was available as a sustained release for a variety of reasons, right? So I think if something's not being tolerated and you have something else to try, it makes sense to try. And if you have a dog that is, having profound arrhythmias and still VTAC and potentially even syncope, and you're already on, it makes sense to change, right? I mean, what I don't know how to navigate is the Holter looks a little better or a little worse. I mean, I don't know what to do with that, right? What's an acceptable outcome? Because I think we're just trying to buy an insurance policy and we don't know what that looks like. We don't have any trials, and we have human data that says they're as bad as they are good. That doesn't mean that's what it would be in the dog. They have a lot more ischemic disease than us, and we humans, not they. We're a they. People. The people.
I think this is a real vacuum in our understanding, actually, of what we're doing. I think we've got a pretty good idea, even about diuretics now, with torezimide and the data that's been published on pharmacokinetics, pharmacodynamics. We really understand those loop diuretics better. Pimabendin, of course, we understand well. The antiarrhythmics, I mean, I think sometimes you could literally, roll a dice to make a decision about which drug to use, because there's just not a right way or a wrong way and not enough evidence to back up the decision making.
Especially beyond Sotalol, because Sotalol is so well tolerated.
It's always that go-to, isn't it?
Yeah, and it works quite well. I certainly have. It's easy to start Sotalol. Even when you're like borderline, you're like, well, sudden death. I mean, I remember being on a panel with Kate Mears, and she's like, well, we were talking about boxers and Holters and arrhythmias, and when you would start Sotalol, and I was like, well, you'd like it to have an indication that you thought it was a bad enough arrhythmia, but you have to flip the coin. Especially in boxers and Dobermans, when arrhythmia, sudden death is so common, and you're like, well, if he has fuel for the fire substrate, and there's a high risk, is that not enough? You've got arrhythmias, even though they're not all that bad. There's I don't know, 1,000 or so, and there's a couple couplets. I mean, it doesn't take me much to trigger for Sotalol in those scenarios, especially if they have structural disease at the same time, right? So if they're already confirmed to be a DCM phenotype on echo, and they're already on pimobendan, because I have seen dogs get a lot better on pimobendan, right? You make the heart happier, and arrhythmias get a lot better too, but it doesn't take much to trigger. I think, can you imagine just a simple registry, which was all you had to do to get into it, or even a retrospective one? You said, I just want to know the signalman information and the phenotypic diagnosis, if you have it, and then the Holter, just the number, some basic Holter things like total number of EPCs, and then things that you could do the lawn score with. So are there couplets, are there triplets, are there trigemini, runs of, something that you could score them. that's already been sort of looked at, and then just drug that you put him on, right? And what happened? How long? When did he die?
Yeah. Yeah.
And how did he die? Was it an unexpected death, or did he ultimately go? Just some simple, you've got to obviously have people who are motivated to be part of these things, but it's, and it's hard. I mean, retrospective is the data gets so untidy, but think about Reveal and the stuff that Phil generated out of Reveal. It's observational and semi-retrospective, because he said, don't give me current cats, give me cats that you know something about for at least 5 years.
Yeah.
And you can imagine that would be, okay, maybe you go to appeal to the residents, like, okay, here's the challenge. The residents are, let's do a registry where residents have to enter cases, and there's a reward-based system for a trip to a meeting, or access to joining a panel, joining the writing committee for this data set. Kind of like we do with Shield, and I know everybody thinks Shield is dead, but it's not really dead. It's still alive. It's just a slow smoking.
Slow burn.
What happened is, remember, Shield was all the breeds that met the phenotypic criteria for DCM, and then we asked, did they get PIMO or not, and we asked about outcome. So the statistician has the data. The problem is the dogs that didn't get PIMO at baseline ultimately got PIMO, and so they weren't a PIMO freak. You know what I mean? So they reflexively gave it. So there's almost no dogs that didn't get PIMO end-to-end, and that means it's hard. Not surprising, because once you have an obvious phenotype, a lot of people were reaching for PIMO end-to-end. But the observational part of that stuff, I was just looking at the other day and thinking it still needs to come to light, because there's some very interesting data there just about the breeds that were reported, and the number of arrhythmias that were present in these dogs. So murmurs were reasonably uncommon, but 50% of them almost had an arrhythmia as a main presentation for evaluation. And I think it changed for me how I teach and how strongly I say, you have to do an ECG on a dog that you think has a sinus arrhythmia. You need to prove it to me, because you're going to miss a single VPC or an occasional premature beat, and we don't listen well and long enough. And so I'd say on a large breed dog, that might be like hearing the murmur in the annual evaluation, is to find an abnormal rhythm. And they just discount anything that's slow and irregular. Everybody just assumes it's sinus. And I think that's a big assumption. Even AFib gets missed that way, right? When it's not fat. Yeah. So I think some of the observational data might be worth putting out there, because it's a large population of dogs across multiple countries.
And that's really valuable.
Yeah. Those large numbers would be so nice. Would be so nice to have it. You just need a good database system, a good system to collect all that data across different countries and centers, but that would be invaluable. Can I just ask you quickly about Sotolov, because I think it's something that will interest hopefully many vets and our listeners. When you have a dog with a DCM phenotype and left atrial enlargement, let's say they're still stage B2, are you ever worried to start Sotolol? Are you worried that you may push them into congestive heart failure when they have big left atriums and so on? Have you seen those cases? Do you change the dose you use? What's your approach?
Yeah, the only thing I change is if, for instance, I have a dog with bad enough arrhythmias that I want to use Sotalol and I don't have access to an echo, like they're not going to echo the dog or there's no echo available. I mean, I would say at least, and so I would reflex to say at least do radiographs, because we also learned from our large breed dog that 11.5 VHS cutoff is probably pretty important in large breed dogs as well. It would be enough for me to say they have structural enlargement and probably benefit from pimobendan. And I'm much happier to start Sotalol in a dog with a large heart that's also on pimobendan. Now, if you radiograph also gives you baseline in case they do tip over, which I don't think happens really. But also if the heart is small, you're going to feel better. And so the question is, if I'm worried, I start on a 1 mg per kg dose and then wait a week and up titrate and have them count breathing rates. I would do it even without radiographs, frankly. If the dog had VTAC in the hospital and I had proof that he had ventricular arrhythmias, even without any other, as long as I didn't think it was related to some systemic disease that needed to be looked after, right? But I would probably give them Sotalol. The harder question is a boxer that's syncopal, and you're like, in theory, every syncopal event for a boxer is aborted sudden death, but they don't all have VTAC. Some of them are Brady, and you don't know without altering them which it is. And just because you don't find any arrhythmia in the hospital means nothing, right? So you're like, okay, you do the 3 minute, But would you treat a dog that was syncopal, like a boxer or a Doberman that had no other diagnostics? And I guess your threshold for treatment, if I did, it would certainly be in the medical record that owner, due to fiscal limitations, owner declined additional diagnostic tests. In the face of a syncopal boxer, the working diagnosis would be ventricular arrhythmias, and we attempted a trial treatment with sotalol. Something that documented that you were going outside the realm. But minimally, it'd be nice to know on a dog you were going to start sotalol that structurally their heart wasn't the size of their head, and even a radiograph should help you with that, and also provide baseline. To me, usually if we start pimobendan in the dog with the big heart, the echo comes back and you're like, I want sotalol, and I want, if they're bad enough, they probably got lidocaine in the hospital. And if they're not bad enough, but you want to start sotalol, you're probably going to give that first dose of pimobendan right now in the hospital. It works within 2 hours. I don't have much concern at all about layering sotalol on top of pimo in a structurally big heart. It's the ones where I have no knowledge of the heart that I might take a more cautious approach to starting it and up titrating. But to me, the target dose is around 2 mg per kg for everybody, or a little more. And I don't. Do you guys think? I don't think it. I mean, I know it's got beta blocking properties, but it's a lot different than giving something like propranolol or even carvedilol.
I think theoretically it's quite a potent beta blocker, isn't it? But actually, the reality is that it's not many dogs I've seen decompensate with it. Although I have seen it for sure. So I guess I'm not as cautious as some people are with sotalol.
I have no problem with up titrating pimobendan either.
Sure.
Right. I'm more than happy to flirt way above the ceiling on the label for that drug. And so if I'm really concerned that it's like he's got terrible arrhythmias, he's been on pimo, he's been a B2 forever, he's seen pimo for a year and a half, he's now bigger than ever and his arrhythmias are horrid, and I want to, add a new antiarrhythmic. I mean, I would, yeah. And that might be more diltiazem for AFib as well. If you have, that's the ones when you've got V's and, then you're like, oh, I don't like mixing sotalol and diltiazem. I don't know. I don't have much of an appetite for that combo. So,
yeah, I have concerns about that, having seen complications.
Hypotension for sure for me on that one.
Yeah. How high do you go with your pimobendan for your refractory DCM cases?
I mean, high, again, I usually go up by 50%, as a rule. So, but the ceiling that I've gotten to probably on some of my really bad terminal cases, I mean, I make per kg 3 times a day.
Wow. Solid pimobendan dosing.
Yeah. But I mean, again, this is a dog who had, it was a biventricular failure dog, right. But it helped. My point is it helped.
And what's the alternative?
And they weren't going to euthanize. So, it was what can I do? I'm maxed out. We're on torsamide. I mean, it was and I was trying to keep the tapping interval manageable for the dog, not having to remove fluid. So it really, I think it really does help to escalate the dose when you're, rather than just thinking more Lasix, right?
Sure.
Think I've got another tool that I can up titrate that might help manage this progressive disease.
Sonya, I'm mindful of time and there's a lot we could continue talking about. It's a huge topic.
Feels like we could be talking for the next 2 or 3 hours, which is
always the way, though, isn't it? There's always so much to talk about.
Fun, right? That's the fun part of it. That's the fun part about listening. Going,
What we tend to try and do is ask our guests to provide our listeners with top 3 take-home messages from the podcast. So if you would indulge us, what are your top 3 messages about DCM, plus or minus arrhythmias, plus or minus myocarditis, for our listeners?
I think that, for practicing veterinarians to basically look for it, right? Like if DCM is rare compared to mitral valve disease. And even, it's only 10% of what's out there, but it's an important disease that we can impact with therapy when we identify it early, but it's like so little of the iceberg is above, right? So to me, it means really good physical exams and probably focusing not just on murmurs, but arrhythmias. I think when you find arrhythmias in dogs, and you need to look for them. And I think that means more ECGs, the renaissance of the ECG in the clinic.
I'm excited.
Bring it back, right? Because people just, so I'd say, arrhythmia, investigation of arrhythmias and keeping an eye out for arrhythmias in your everyday annual wellness checks in animals that otherwise have no. So that'd be one. Surveillance for arrhythmias. And then I guess that treatment matters. So finding a way in your practice to get to the echo in the right dogs. So whether that means having a plan that is a surveillance plan that involves some of these other monitoring tools we've talked about, whether that's finding an arrhythmia or using a biomarker or even using a radiograph, for goodness sake. I mean, it's if you have an index of suspicion, something should be done. And if that reflex step can't be an echo, maybe you could think about how you might stack the evidence to get to the echo. Does that mean so clients sometimes need to be convinced of the value of an echo. So the pet part of that equation. I don't know, what's your third one? Those are probably for me the trying to think about novel ways to approach the gold standard and get to the point of the gold standard, and then surveillance in particular with emphasis on arrhythmias in your physical exam. What's your third? Get a third one?
I think for me, listening to everything we've talked about and thinking about it, it's really great to be thinking about contextualized care. Now, it's a bit of a buzzword at the moment, this contextualized care. But what I mean by that is we're up against it. The client maybe has some financial restriction or just doesn't want to keep coming back, doesn't want to drive back and see the cardiologist. What will the test impact? Will it change what we do? And I think actually using that reflection, your example there about, are you willing to add more antiarrhythmics if the dog's well? What's the point of bringing back and repeating the halter? I like that. I think that's a good take-home message too, that contextualized care is important and it can be applied at a more specialist cardiology level.
Yeah, that if there's no actionable step, that sometimes the investigation is hollow. Yeah,
it's for knowledge that may not change things for the dog.
Yeah, okay. Brilliant. Sonya, thank you very much. It was great. Really, a lot of very valuable inputs. So this is it for us. Thank you very much for joining our podcast.
Sonya, thank you. It's been a real honor, and what a great amount of material we've covered in an hour's podcast. Thank you so much.
And do not forget to follow us on socials. Our handle is @heartbeat_pod. And keep checking for our next episodes on our season 2. Bye, everyone. Thanks very much.